Hello, I'm Nimesh Desai. I'm a psychiatrist and a public health professional by training. On For the National Ability Summit version 2, 2021, we're doing this session on the need for aftercare homes and community-based rehabilitation to achieve inclusive and independent living for persons with mental illness. I am athletic to medium heavy set build 6-foot person who right now sports a entirely white silver French beard and black and white hair on the top of my head. I'm wearing a white shirt and a deep beige sleeveless jacket. I hope you're all able to hear and see us well. Allow me to introduce two of my panelists. One, Pallavi Rohatgi is a lawyer by training and has had actually the good fortune of practicing in both geographies as an attorney, US and India. She's on sabbatical from the legal profession, works with the organization in Chennai called the Banyan, following her lifelong passion for mental well-being. And she's now the chief for the Banyan's scale-up of its model project Home Again, across 10 states. Home Again is a project that I'm sure she will mention and talk about. That's been a model for one of the aftercare community-based services. She also leads a young talent group to create cutting-edge content for mental health awareness. Pallavi, thank you. Thank you for being here.
Thank you for having me, Dr.
Dr.Achal Bhagat is a long-time friend who is a senior consultant psychiatrist and psychotherapist who trained at PGIMER, Chandigarh and Oxford, UK. He is the chairman of the Psychiatry Mental Health Services at Indraprastha Apollo Hospital for 25 years and more in Delhi. He's also been the chairperson of an NGO that he founded, which works with multiple stakeholder groups on mental health issues in South Asia. He's the chairperson of ADI, an organization working for rights of persons across all types of disability. And as I've known for many years, he sees himself equally as a mental health activist, as a psychiatrist and a mental health professional. Of course, training a lot of barefoot counselors and ground level mental health workers. Achal, thank you very much for being here. Really, it's such a pleasure.
Thank you, Nimesh. Thank you. Lovely being here.
We are going to, the three of us, I might say, are going to carry this conversation forward. My being the moderator alongside whatever I can contribute from whatever we have learned together jointly. Let's begin with one might, Achal. Where is the position in India, South Asia, and in the global context for this endeavor, would you say, of achieving or helping persons with mental illness achieve inclusive and independent living for persons with mental illness, aftercare, so to say, following treatment?
Thank you, Nimesh. This is Achal. Just to follow Nimesh on my description first, I am more heavily built than Nimesh, fairly heavily built. I owe this to my genetics. I wear spectacles and I have silver gray hair and a silver gray mustache. Chubby cheeks and a double neck, and I wear a dark blue shirt right now. And behind me is a painting by an artist. It's a watercolor. It uses wash technique. I love paintings as well. So, coming back to your question, Nimesh, where are we? I think. At the level of philosophy, things have moved significantly. At the level of value framework, things have moved significantly. Especially after 2007, 2008, the UNCRPD, the United Nations Convention for Rights of Persons with Disability, with a specific emphasis on mental health and other mental health disabilities, things have moved significantly because of the concept of legal capacity, because of the concept of liberty, because of the concept of choice, lack of torture, lack of discrimination, family life, focus on family life, the focus on independent living and community living, focus on education and livelihood, and especially legal capacity. Point number 5, finance being under your own control, and your right to own property, and right to manage your own money. All these things are significant value framework changes. So from being abandoned and incarcerated, or being dependent on welfare approaches of homes or post-institutionalization, community efforts, which in themselves became micro-institutions. Beyond that, I think new experiments are in place. But the most important thing is that people now know that they have the right to take their own decisions. Now, when you try and convert that into services, in India and in South Asia, the services are limited. We are still struggling with, halfway homes, quarter-way homes, NGO centers, and trying to get people back to their homes. And there is a problem of a revolving door phenomena there, people becoming homeless because of that revolving door phenomena. So I don't think the experiments are very successful in trying to find the ideal solution of converting the value framework to an everyday reality for persons living with mental illness. When will that happen? How will that happen? I think it's a journey. I think it's a long journey. It is likely to happen over a period of time. And I'm sure there will be more and more opportunities that arise.
Thanks, Achal. Thank you so much. This is Nimesh. If I might just add to that, I guess, Achal, you and I were also part of some of the judicial activism and the committees that came through judicial activism in Delhi and this part of India that also synchronized, fortunately, with the CRPD implementation. And so there are some stories that you might share. But yes, broadly, it would seem that while at the philosophical, conceptual plane and in terms of sensitivity, while a lot of ground has been covered, at the ground level for majority of the persons with mental illness, anything towards independent or inclusive living for persons with mental illness is still a far out dream. And Pallavi, would you please share the Home Again project that the organization Banyan has had, which is essentially talking about what Achal and I were mentioning. I must also say that we are going to have your colleague Kishore talk about the larger aspects of Banyan, the organization, and the engagement of persons with mental illness in treatment and rehabilitation services. I request you to really focus on aftercare services, especially towards autonomizing persons with mental illness and giving them choice, as Achal was saying. Please.
Sure. Thank you, Dr. Desai. This is Pallavi, and following suit. I am medium built in terms of weight, but I am tall. I'm 5'9" for a woman that's considered reasonably tall. I wear glasses, and currently I'm sporting a large red bindi, which gives me strength when I have to appear before such individuals like Dr. Desai. With that, just to give you some background, the Banyan, we run critical care, critical time intervention and hospital-based setup called the Emergency Care and Recovery Centers. These are basically first point of contact for individuals with mental health issues and mental illness who are homeless. Now, over time, we found that a lot of these persons who are receiving treatment in our ECRC for short had nowhere to go, and even though they had recovered and their symptoms were managed with medication and other interventions, they were still stuck in the institution. So in about 2014, we piloted Home Again with a grant from Grand Challenges Canada in the state of Tamil Nadu, where we transitioned groups of 4 to 5 women into these rented homes, which are set up in the midst of a vibrant community with access to banking services, access to shops, to religious affiliations as per the preference of the individual. And that was the first time we did it in 2014 and 15. And the structure is really quite simple. It's 4 or 5 people who live as an affinity group, as a formed family in the community, in rented homes. And they have support from non-technical individuals whom we call personal assistants, who are trained by the Banyan on the basics of mental health, on identifying crisis situations, when things are escalating, so that they can access medical care, psychological treatment, psychiatric treatment as soon as possible. But more than all of that, the PA, the personal assistant's role is really to help these individuals integrate with the people around them, integrate with the neighbors, integrate with, just a simple exercise as going and buying biscuits from the corner shop. So, inculcating a sense of agency, financial independence, and, the focus has throughout, including when the decision is made whether they should move to a home again setup or not, is what is it that they want from their life? What is their life goals? And understanding that and giving them the option to actually move back into the community, rediscover their, who they are and their own independence. And over a period of time, we actually found, and we did research on this, we administered some standard tools like quality of life, community integration, questionnaire, social distancing, and who'd asked for, reduction in disability. And we found that compared to individuals who stayed behind in these institutions, there was a marked reduction in disability at the 6-month mark, at the 12-month mark. There was a marked increase in community integration at the 6-month mark and 12-month mark. And on the basis of that, we did a transition to scale 2, where, again, under grand challenges, where we looked at setting these homes up in Kerala and in partnership with Asha Deep in Assam, where we set up home agains in Assam as well. And the findings seemed to resonate. It wasn't a one-off thing. It seemed to have worked. At this point, we are actually trying to see how this model can be scaled. We are looking at setting it up in 10 states in India, and even in the northern province of Sri Lanka, which will be the first time we'll be doing this in another lower middle income country outside of India. So overall, the basic structure, as I said, is really simple, but the consequences and the results that we found was significant, and including where we found that the reduction in stigma. One case study, like one example I can give you is, first when these people with mental illness moved into these homes, the neighbors would have nothing to do with them and be like, the kids should not go there, children are not safe. And over time, actually now some of these women are caregivers, take care, give daycare to the children of the neighbors when the parents go to work. So that huge shift in how, people with mental illness is perceived was seen. And, along the lines of what Dr. Bhagat was saying, this is something that we can look to replicate in other states, and of course understanding that each state has its own cultural context. In India specifically, we are so varied in terms of language, in terms of culture, in terms of how we perceive women living on their own. It is a challenge, but it is something that seems to be working, and we hope to show that this model can work across different cultural contexts.
Right. Can I, Pallavi, please supplement that with one or two other queries that I have? One
Sure.
is, to what extent can we believe that the Home Again project, poignant as its title, has taken care of what Achal was referring to so well as the revolving door? People going in institutions or in and out of one or many institutions, Excuse me. And so, to what extent do we believe that has been taken care of, at least in that population? And two, do those persons have a choice at the time of entry or exiting or during the stay?
So Dr. Desai, one of this revolving door issue is a big one, and what this home again model is, it's a long-term plan. It is not a halfway home. It is not a transitory home. It is their home. Of course, you may change homes, just as you and I, if we live in a rental accommodation, we move from one house to another. That is always, that can always happen. But it is their home. It is their family. In terms of choice, I mean, the focus on the Banyan's ethos and focus has always been choice-based. We have a rights-based approach, a choice-based approach. It is always the individual's decision whether they wish to leave and move into a home again. And we also found that some service users felt that it was too intense for them. They could not manage to be in a community setup. They had been in an institution for too long, and they just wish to go back to the institution, which is always respected. So that does happen. But the idea is that we don't fall back into homelessness. And for that, there are support packages. So we work with these personal assistants who are trained. These personal assistants, just to give you a background, are not mental health professionals in that sense. They are not trained. We are looking at individuals who are 8th, 9th pass, who are peer advocates, who have had lived experiences of homelessness, in certain cases who have been service users who have now become personal assistants. So there's a lot of individual experience-based care that is brought in to these homes, with the idea that relapses are reduced, with the idea that in the event there's an escalation, there's an understanding that I can go back to a hospital if that is what is required for that period, but this is my home and I come back to it. So it is not a temporary solution. When I say it is a home again, this is a lifetime commitment from us, from the client, from funders. But we understand that sustainability has to be built in, right? That is a huge challenge. So for that, we work with these individuals. See, one has to actually go back to the core root cause of why they are homeless, why the mental health issue has been triggered, the bi-directionality of poverty and homelessness and mental health. So, keeping that in mind, we look at encouraging them to be independent. When I say be independent, we also look at livelihoods, skill development. Some of these service users who become personal assistants are paid. They are paid as the personal assistant would be. So they gain a whole lot of financial independence. So it's a very multi-pronged approach where we are looking at different aspects of care, which is not just medical care, which is not just biomedical approach.
Sure.
Thank you, Pallavi.
Nimesh, can I come in here? This is Achal, and this is just a query to you, Nimesh, about the possibility of home again being seen by the state mental health authorities as a mental health establishment, because they are interlocutors. You see, the NGO still is running the place, and the state mental health authority might think of it as a mental health establishment as opposed to it being a home or a family, because legally it is not a home or a family.
Sure, absolutely. Indeed, I'm happy to say that what Pallavi described some 5 or 7 years ago, I have visited and seen those services that Banyan runs. And for last couple of years, we have now been discussing, Achal, setting up what Pallavi said, Home Again replication project in Delhi. And so with the state government and SMHA, I think it will be a wonderful idea and add to the sustainability of this whole idea of Home Again project. I'm sure all of us together can do that. In a sense, if I might say, the state will have to take responsibility for this kind of services. And in the legal framework being seen as MHE, I'm inclined to agree. But I wanted to ask you, Achal, from our joint and yet slightly different experiences. What I think Pallavi hit the head on the nail when she said that projects like Home Again, or any community-based rehabilitation, autonomizing rehabilitation CPR for PMIs would essentially be for preventing homelessness and destitution on account of mental illness. And so how would you, for our friends who are listening in, describe this whole relationship between homelessness and destitution on the one hand and severe mental illness with disability?
Right. So I think that the two assumptions of incapacity and dangerousness are the key assumptions that lead to homelessness or neglect or exploitation or invisibilization or exclusion. So unless those assumptions are challenged, right, and those assumptions would be challenged by success stories of people being able to take decisions, people having the opportunities and being able to use those opportunities with support sometimes and without support many a time to be able to take decisions, and the assumptions of dangerousness being diluted and challenged by assumptions or narratives of success or narratives of participation in community. So I think the conversations have to move from towards participation in community, towards ownership of the community. Reclaiming that space in the community is essential for the movement of people living with mental illness. And eventually interlocutors like us need to gradually fade away. Because till the time the interlocutors remain, there remains a hierarchy. The us and them is created or concretized by us, the middle ground, you see, because we are the protective layer, so to say. That narrative, unfortunately, feeds into the assumption of incapacity, and that narrative needs to be challenged repetitively. And that's why the rental arrangements, for example, the rental agreement in a home again should be to the group of people who are inhabiting the space. The rental the grant, the micro grants that happen, for example, is the processes that matter. You see, how does the funding agency and the operating agency provide a microfinance grant to this group? It becomes a self-help group then. And how does this self-help group then look after themselves? And self-help groups are a phenomena that are known to India, that are known to Bangladesh, that are known to most of the developing world now. How does this self-help group then function to look after itself with support systems? So that identity that Varija was talking about when she introduced the whole Ability Summit, the identity of a person has to be moving away from only the mental illness identity to the identity of the person as a person. So reclaiming the personhood is the most important thing, Nimesh, for me.
Oh, absolutely, Achal. And I've learned so much from you and the other colleagues about that over the last 2 or 3 decades, especially around UNCRPD and after that. The personhood idea, Pallavi, if you'll please elaborate a little more from the Home Again project and other such projects that you know across the world, across different countries. Are there other different models being tried out? I mean, this is one. And if you'll also please crystallize for us what would be elements of a good project, model project for anyone to follow.
So yes, of course, there are other models around the world. I mean, this is Home Again is one of many with supported living as a basis for, as Dr. Bhagat said, enabling individuals to find their personhood. I mean, that is the key and that is the focus even for Home Again for us. And just to reel back a little and respond to Dr. Bhagat's comment on the rental agreement and being in the name of the individuals. Yes, that is a movement that we are working on, and there are some homes which are completely independent living where clients first, have moved out, are living on their own with support from us, in ensuring a symptom management or any other support that may be required, but they are completely independent. So that is the route we want to follow, and that is the route that we are going towards. But it is a challenge with finding homes that allow that. So it is a process, I think. Coming to Dr. Desai's point on other models, and there are WHO recently launched a community-based mental health tech pack community guidance booklet, and they had identified several models from around the world that focuses on community-based mental health, which is rights-based, persons-based. So some of them that I thought I'd raise here was one that is very actually similar, I would say, in some sense to the home again, which is called Hand in Hand. This is in Georgia, which is an upper middle income country, where basically they have 4 to 5 people staying in these homes, supported by assistants who are trained with mental health issues. One of them is Hand in Hand. We have the Keyring in the UK, which is where people live in a radius and build a network. So what happens is that about 10 homes in a walkable distance radius, where they are each other's support systems and networks, and they also have supporters in terms of people who provide other support like medical, other interventions, etc. We have the Housing First in the US, and its premise is that before we can resolve any issue and enter into helping people with reclaiming themselves, the first thing an individual needs is a stable home. I mean, without a home, at that point you are focused on just managing, just getting by. I mean, to use an Indian phrase, in roti kapda or makan, this is your focus at that point. So once we which brings in the basic income concept and such other concepts. So there are various models, and based on our cultural context, different countries, these have variations. Home again is, I can't say is the ultimate solution, right? That there will be learnings from say, for example, Delhi. The challenges in Delhi will be different from the challenges in Tamil Nadu, and challenges in Tamil Nadu will be different from the challenges in Maharashtra. So one has to be. It's a dynamic program in that sense. One has to be open to the idea that overall structure is there as long as we are following the base criteria of choice, personhood, independence, and enabling individuals to find their way. We are just supporters. We are not in the sense that the facilitation is done by the person themselves. We are giving them the tools to be able to go out and do what you and I do. I mean, at the end of the day, whether you're homeless or with mental health issues, your aspirations, your goals in life, they are the same. I want to do this and that, and I want to have a job, or I want to take care of children. It is irrelevant what your mental health situation is to have such aspects, aspirations. So I don't know if I answered all of your questions.
Yes, you did. Can I ask both of you if I am getting this correctly from what I've known till now and from our conversation? What we can crystallize as its elements for all such efforts be, firstly, that it's recognizing the personhood of the individual involved. It be enabling. It be deprofessionalizing. It'll be about our role, whoever catalyzes, be minimal, and helping persons towards independent living for ADL as well as livelihood, including hard economics. And as Achal said, and I really like that idea, removing ourselves or making ourselves less and less relevant, the interlocutors. Would that summarize the elements of any such effort, or would there be more?
This is Achal. One more thing I would add, Nimesh. It has to be resource rich, because doing all this could be seen as abandonment as well. right? So if you walk away without creating the resources, a network of resources, and without managing the network of resources, without managing a network of safety nets, then you have created a horrendous experience for people.
Yeah. That brings me to my concern, if I might say. Both of you at different points of time in this conversation referred to this whole process of independent and inclusive living for persons with mental illness as a journey and a process that we as a country or as South Asian countries have kind of embarked on. That being the case, is it appropriate to recognize that to prevent homelessness and destitution on behalf of, on account of mental illness or severe mental illness related disability, what we might need to do in next few years is actually offer a spectrum of choices or options available. Home again kind of projects or group assisted living or group supported living projects will be one. Although we did say halfway homes and long stay homes can actually become institutions, would we agree to, and this is a bit of a ticklish issue, would we agree to a spectrum of choices for the next few decades, or what solutions be, would you say? Either of you, please, if you'll take it first.
Right. I have a crack at it. This is Achal. So I think a continuum of resources is important, right? The difficulty that I face, or we have faced as an organization in the last 25 years, is that you create a model. For example, we created two models, not as well documented as Banyan, but we created two models. One, a helpline for students who were dying through suicide in late 90s, early 2000s. That model itself was one element of a service, and that became a national policy. And unfortunately, the only thing that is pursued now is a phone line. That is not enough. Similarly, we created a model called a daycare home run from a basement in a South Delhi residential flat. Now, that daycare home was a limited service. One service. It does not fulfill the objective of what the need of a mental health system is. So when we are creating mental health systems at a policy level, and that's where the state needs to come in. The policy needs to create examples, create models, create processes which are not rigid, which are flexible, which can evolve, which are modular, which can add and change and grow. Unfortunately, the policymaker looks at one thing, passes a high court order, and policy is led by judicial activism and at times. That order is so restrictive at times that you want to generalize that or change that. It becomes a problem. So I am all for a continuum of services and resources for a continuum of services, rather than one or two or five activities which have been seen as successful. Because if you don't evolve, then you don't get a Zomato, then you don't get Uber, then you don't get Google, then you need to evolve. Where there's a Zomato, there has to be Swiggy.
So if I understand you correctly, Achal, and this is Nimesh, what you're saying is that a continuum or a spectrum of services being planned and implemented is essential as long as we all collectively ensure that there's a full range of residential and non-residential CBR for PMI available, which is dynamic, which is flexible, which is evolving.
Yes.
Pallavi, what would you say with all your background experience?
So, this concept that, this is Pallavi, by the way. So the concept that Dr. Bhagat brought about continuum of care, that is such a critical thing that when policy is being made, we seem to forget, because mental illness, like any other illness, is not a straight line, right? I mean, it is a curving wave, and access to, just that I've moved somebody to home again cannot be the final solution for that individual. We have to look at the person, understand what their specific needs are and work on building customized care plans for such individuals. And they should be able to, one is they should be able to access this care, but two is also that they should be aware that they can access this care, right? And so this awareness, this one of the things that is really, really important, I feel, is this grassroots level awareness on mental health issues, training individuals, as Dr. Bhagat was talking about, to identify. Early identification is such an important aspect, which if we incorporate as part of our one of our spectrum of care, then it possibly, and has shown, I think empirically been shown to reduce future homelessness, as a consequence of mental illness. So it cannot be a straight line. As the disease or any other illness is not a straight line, the solutions cannot be a straight line. We have to know that and find various modifications, models that is contextual to the individual.
Sure. I'm glad we all agree about that. If I might briefly share, with help from NGO friends like Achal and you and many others, and our private sector friends and policymakers, and of course the judicial activism, what's been possible in Delhi, as one example, is that continuum that we spoke about. The hospital-based, not necessarily residential admission-based, but hospital-based or treatment center-based services, the post-treatment services that we are talking about in this session, and the engagement in treatment or pre-treatment services, including early identification and through legally, ethically correct means getting people who require treatment with severe mentally related disability to treatment. Do we know of many other situations where that effort has been made, Achal or Pallavi, to really try and build a spectrum, a full continuum of care in a state or in a city as a planned manner? Because one hears of and one knows of, efforts. Banyan is of course one example that again seems to do all three as an NGO. Do we know of many other examples, and what are the experiences or challenges there, as you know?
Right. I this is Achal. There are some examples. For example, if you look at Ashadeep, they run a range of services in Assam. Similarly, if you look at Anjali in Kolkata, they have a lot of community-based kiosks. They also go into the hospital, so they have early identification, peer counseling, and hospital-based rehabilitation programs as well, and a livelihood program, a laundry that they run, which is run by people living with mental illness within a hospital. And so there are a range of programs available, but has the state taken an initiative to have, let's say, a state mental health plan, which has a continuum of resources, money for it, standards for it, human resource for it? I think under your leadership at the Delhi State Mental Health Authority, Nimesh, it has been tried, but of course we both know that how many barriers there are into executing that. But conceptually, I think Delhi has done well.
Let's even identify, Achal, if I might say, let's even identify that for our discourse. Both we and I happen to know from Delhi some of those barriers and challenges, if you would.
Right. Okay. That's the difficult question. I think the mindset barriers are the best ones that I can talk about.
I'll take that up, and if you'll supplement, please.
Yes, please.
One, there are of course mindset, attitudinal issues at almost every level, especially when it comes to persons with mental illness or persons with severe mental illness with disability. Sure. Earlier, as you had said, the presumption of incapacity or dangerousness in the mindset. Two, there are still structural and systemic issues, especially when it comes to resource continuity and sustainability of programs. The third, of course, is the upscaling of it. There are. What Home Project and a few other projects do very well is the upscaling, and there I'm happy to say the pre-engagement, and we'll talk about this in the other session, but since we're at it, the post-care programs, hopefully in Delhi, will become a little better. Tamil Nadu is doing well, Kerala is doing well, Karnataka is doing well, Assam, like you said. Delhi also will have that. Besides, of course, the whole issue of, if I might say, frankly, at least lack of active interest, if not apathy, by the core mental health professionals concerned. In key positions. Would you Achal, want to comment further or add to that?
So this is Achal. So I don't want to make it Delhi centric, but that's where we come from. So one of my saddest and the biggest failures of my professional life, I would narrate that. Right, I was chairperson of a large institution called Asha Kiran, which was meant to care for people with intellectual disabilities. And before I became the chairperson, I had already written a white paper on it, which had asked for its closure. And I, in my resignation letter, I ended up saying the same thing. Unfortunately, years have passed. Every winter there are deaths. Every time there is a High Court or a Supreme Court order, there have been investigations from women's organizations, from child rights protection organizations, from mental health organizations, from disability organizations. The number has grown from 700 when we started out to about 1,300 now of people living in what could only be called inhuman circumstances. If you go back to that report where Justice Venkatachalaya commented about, the walls of Murshidabad being covered with human lice, Murshidabad Mental Hospital covered with human lice. It's not much better than that. Although, blaming it on the staff there is not the solution, because they try their best, because they are only a few people and they can't determine what is happening there. So that's one of the saddest and the biggest failure of my life, that I was there for 3 years, couldn't do anything, just anything, except hold 6 meetings or 10 meetings or whatever, and talk about it. Unfortunately, those are the barriers. See, why couldn't anything be done after all the lens, the lens is on it, yet nothing changes, because the narrative is set that this is how people will survive. The simplest solution is to have a cluster around that place and hire small homes and start gradually deinstitutionalizing, with that place becoming the hub for people to come in during the day and for support to go out into the community. And there is so much land that can be used to do that. But who will take the risk? Who will be accountable when the next person? So many people die in the institution, and there is a degree of a system of accountability, but who will be responsible when the next death happens in the community? And that fear that the professional is put into, that you would be responsible and not the system, not the lack of resources, that puts the professionals away. Who will build the human resource? I've been, Nimesh knows this, I've been crying out loud saying you cannot depend upon MPhil clinical psychology or MPhil psychiatric social work or MD psychiatry to change mental health in this country. Like Dr. Ved, you have to take mental health away from mental health professionals for it to be implemented at the level that needs to be implemented in India. So how would, Pallavi is not a mental health professional, yet she's managing a program of 20 homes, and she doesn't even have the requisite, qualifications of a psychologist or a social worker. Yet she is managing. So people should manage with basic skills. There should be skills so that there are no irwadis. You need to prevent irwadis, but you cannot be so restrictive in the way you provide support. And if you become so restrictive, of course, you lock people up because of their safety. that will be the argument that you will give.
This is Nimesh. Achal, not only their safety, like you said, your own safety as the manager.
Yes.
And as you know, I've lived at 22 years here at IHBAS. Yeah, that's a difficult one. But would that also not mean that there is essentially lack of genuine will, professional and otherwise? Pallavi, would you comment on what crystallizes in my mind from what Achal has been saying? And he and I have been talking about this for long. That deinstitutionalization that was and is still so celebrated is not the final answer. That's just one step. That beyond deinstitutionalization, you'll have to have really robust multiple models of community-based care, prevention of institutionalization, prevention of homelessness on account of disability or mental illness.
So, this is Pallavi. As Dr. Bhagat was talking about the hub and spoke model, this is something that I think we need to look into with greater depth. The fact that you need institutions, they serve a purpose and they are there, then they should be there. So, but just as you go, if you have a heart attack, you go to the hospital, you get treated for it, and then you're discharged. You don't sit in the hospital for the next 10 years, with a heart condition, because you might get a heart attack anytime. So I will just stay there. It doesn't work like that. So, why is it that we don't look at this hub and spoke model where we say that, yes, that there may be relapses, there may be escalation of symptoms, maybe I need to be readmitted, but does that mean that is what my life should be, that I should be in an institution? So one is that. The second is we don't really tap into the lived experiences, pool of people. I mean, there are huge number of people who have had lived experiences, who have recovered and may have an interest in supporting others who are going through that. I think that it is important for different organizations to identify this resource pool. See, actually, on the, as Dr. Bhagat was mentioning, human resource and finding people who want to do this and take the risk, is very difficult. I mean, the biggest challenge I feel most of us have is human resource. Second thing that, for example, now we are trying to do home again in a few states and we are going house hunting, right? And the minute we mention that, the person will be happy, in the interest of full disclosure, we do mention to the landlords that these individuals may have mental health issues. And they have no, it's a huge, long process. We have multiple meetings with the landlord, and then the landlord agrees and the neighbor says, we can't do this. So what we need really is identifying that, bringing on a general informational campaign. I mean, the government does anti-smoking campaign with this horrific video that they show before a movie. Why don't we do a mental health campaign? Right? Why don't we say that, mental health is just like any other illness, is just like any other illness. And that institutions is, this invisibilization is not the solution. Just because I don't see somebody who is mentally ill doesn't mean they cease to exist. So, this transition in the mindset and this journey is what I think we need support from policymakers, from the government, and simple things like just informational access, education, all of that will help in getting a larger number of people coming forward. I mean, as I said, that I actually, as you're right, I have no psychiatry background. This is a space I'm interested in. I know what my skill set is. I'm not a psychiatrist. I'm not going to clinically treat a person. For that, I will find you. I'll go to Dr. Bhagat. I'll go to Dr. Desai. But for me to run the program, I just need to have a sense of empathy, a sense of, understanding that this is a need and I can do this. So, yeah, I mean, that is a challenge as a community as a whole. I mean, it's a cultural drawback, honestly.
Thanks, Pallavi. Thanks so much for that. Are there any other concluding thoughts from either of you, please, before we draw to a close? I'm going to try and summarize, or let me do that and then respond to that if you like. It would seem that post-treatment or even independent of treatment, for persons with mental illness, especially severe mental disorder, related disability, community-based programs for independent and inclusive living is something that we have begun to understand, begun to recognize the need for, but there are only a few pockets of good model demonstration projects that we really need to upscale and sustain much larger. Two, that we need to see that as a journey which is dynamic. Three, that we need to see post-care programs as part of a continuum of mental health services, as Achal said. And four, that homelessness on account of or destitution on account of mental illness or any psychosocial disability is actually the major frontier for the 21st century. And if we want to avoid or reduce that, we really need to strengthen our aftercare programs for independent and inclusive living for persons with mental illness. Please feel free to modify or add to that.
That's a lovely summary, Dr. Desai.
Thank you.
I think it is. The only thing that I will underline is that Article 12 of UNCRPD, legal capacity. If we stay with that, not the political version of legal capacity, the everyday version of legal capacity, the lived version of legal capacity is what we need to be able to change the premises that people run on. And second, a suggestion to all of us: instead of grants and projects, let's create India Mental Health Fund. And one of the things that India Mental Health Fund should do is assign 50 crores for startups in mental health and give it to young professionals from any branch who want to start a continuum of resources. Let it function as anything else functions.
And at the same time, Achal, you will agree that, like we have been discussing today and otherwise, like Delhi, we are trying, and few other states are trying. The state must take its responsibility, fair share of responsibility for well-resource provided continuum.
Sure. But I'm saying that creating innovation is, you need to plant seeds for that.
Sure, absolutely. Yeah. Pallavi, any other thought?
And there's no other thought, but just as a concluding remark, I just wanted to add that I would urge the youngsters of today, and I would urge people from different backgrounds to come forward and participate in this process and this transition that's happening in the country, which has started. And mental health after this COVID-19 pandemic has become the buzzword, and everybody is, on it. And it's, you say mental health, and, there are 20 people who come forward. So we are at a point, unfortunately or fortunately due to the pandemic, that, everybody is aware of this phrase, mental health. And the government needs to step up at this point, look at sustainability of these programs. I mean, of course, funding has a deadline, has an end date, even from funders. And unless and until various stakeholders step up and, support the journey, it is not going to be sustainable. And we need the government to come forward. They are the, we need various other industries and policymakers to come forward.
Thanks, Pallavi. You're prompting me to place on the table the other thing that has bothered me. And this is Nimesh. I completely agree that mental health seems to have come to the forefront, but I do see a huge class bias there. What the mental health people are talking about is the depression and anxiety and the PTSD that people like you and I of the middle class or the upper strata go through. The homeless or the destitute or the really underprivileged, marginalized people with severe mental disorder is not still on the agenda, I dare say. Indeed, I have no hesitation in saying, being part of the system, that at many levels, in the COVID policy in last 1.5 years, the people with severe mental disorders were a blind spot.
That's true.
And I've been part of the system, and I really say that with a sense of responsibility. And so I'm with you, Pallavi, that let us capitalize on this, but also not overlook this group of persons who really have a huge need.
Absolutely. I mean,
Sorry.
Go ahead, Dr. Bhagat.
Achal?
Right. I think that we will miss the wood for the trees if we just follow the current emphasis on mental health the way it is. It will become a passing fad, and people's real lives are not a passing fad. People go through recovering from mental illness is a journey. It's a difficult journey. It does not happen through just sharing what you're going through. It requires a lot more resource and a lot more strength from people around you, from the community around you, a lot more understanding, and therapeutic processes which are not available. Not everybody can go and sit in front of a therapist for an hour every week. That model of face-to-face therapy, which is a Western model, which I follow because I'm a trained therapist, is my bread and butter. But that model, as a public health activist, is not the model that we are looking for.
No, I agree with that, absolutely.
So we are saying that let's all collectively take responsibility for the seriousness of the underprivileged and the marginalized, severe mental ill persons with disability, especially for the independent inclusive living. Thank you so much. Pallavi, Achal, it's been a
Thank you.
Thank you.
Bye.
Thank you. Bye.
Bye.